Yeah, we can see that, sir. It's visible.
Uh,
But
do you
not
want
in a
me to
slide.
leave it on, or should I just move one slide? Can you see that change?
Uh, no,
Is it changing?
Nandini,
no, sir, it's not changing.
Nandini, when should I start?
Mm.
Hello, good evening, everyone. Am I audible to everyone?
Yeah. Yeah.
All right. Good evening, everyone. It gives me great pleasure to welcome you all to the fifth and final session of the Transdisciplinary Perspectives on Health lecture series hosted by the School of Psychological Sciences, Christ deemed to be University Central Campus, Bangalore, in collaboration with wove, the Wellbeing Clinic. I would now like to call upon Dr. Veena Shri to introduce the session and our esteemed speaker for the day, Dr. Mario Vas, Consultant General Physician, former professor and head of the Department of Physiology at St. John's Medical College, Bangalore. Dr. Veena Shri, over to you.
Thank you, Sai, for opening the forum. A warm, happy evening to everyone, and I take this honor to introduce Dr. Mario Voss to our vibrant group of health enthusiasts here present in the virtual platform. Dr. Mario Voss is a well known physician, researcher, and an academician with a special interest in physiology, public health, medical ethics, and the history of medicine. Sir has completed his MBBS and MD in physiology from St. John's Medical College, Bangalore, and done his fellowship at the Baker Medical Research Institute in Melbourne, Australia. Dr. Voss has a strong commitment to public health and spent his 3 years working on leprosy and tuberculosis as a part of his rural service bond. He has also been actively involved in public health research at St. John's Medical Research Institute, including projects on biobanking and genetic research in India. Dr. Voss made a significant contribution to the field of physiology, being a former professor and head of the Department of Physiology at St. John's Medical College, Bangalore. He has served as the head of the Division of Health and Humanities at St. John's Research Institute and has curated Zen S.L. Bhatia Museum of the History of Medicine. He is also on the editorial board of Indian Journal of Medical Ethics. With this very brief introduction, I welcome Professor Mario and leave the forum open to him. Over to you, sir.
Thank you very much. I think some of your introduction has overlapped with that of my wife, who also has the same initial. But thank you all the same. Uh, I just want to check one thing before I proceed. Uh, I'm just changing a slide. Has that slide come to you all?
It's not changing, sir. It's in the first slide itself, even now.
Okay. All right. Shall I redo it?
Yes,
And
sir.
okay.
Yes, sir. Yes, sir. Yeah, now it's changing.
No. It's now not full screen though, isn't it?
No.
Shall I continue this way?
That's fine, sir. That's fine.
Okay. So I'm actually going to divide this talk into two parts. The first part deals with the place of the humanities in health. I dislike the term medical humanities for a reason that will become clear as I proceed. And the second part will deal with the application of medical humanities to lifestyle disorders using a single example. But I hope the same framework can be used for any other lifestyle disorder. So, in this very interesting article by James Giordano, he states we cannot extricate medicine from the social fabric in which it is enacted, nor is it logical to do so. And one of the problems that medicine faces today is that it has evolved in a silo of its own, and it is often extricated from the social fabric. And I would argue that the humanities in health brings that social fabric back to medicine. So, what do we mean by the humanities in health? Uh, the humanities is basically the study of humanity. And when we look at the application of humanities to the health sciences, it is often viewed through a very narrow prism of literature, art. Narrative medicine has developed in a big way. But I would argue that should include all disciplines that help us better understand the human person and which allow us to become more self aware and humane practitioners, regardless of which profession within the health stream we place ourselves in. And so, if it is all forms of inquiry that help us to understand the human condition, then we must expand that uh, notion of humanities to include other aspects of inquiry, such as has been displayed in this slide. So the question that then arises is, why should we include humanities in medical practice and in medical education? Traditionally, medical practice has evolved, at least over the last 150 years, largely dictated by the methods of science, which attempt to enhance technical judgment, and therefore an integral part of clinical judgment of the doctor. On the other hand, arts and humanities helps us with interpretation and insight, context, and increasingly with the understanding of a broad framework of ethics, which allows us to develop humane judgment. And it is now an accepted view that clinical judgment devoid of either technical or humane judgment is incomplete. And it is these two together that best serve the interests of the patient. So, how did the modern health humanities movement evolve? If you look at ancient medicine, you will observe that to a large extent, the practice of healing was largely an art. This is because uh, they were limited in their abilities to investigate the nature of disease, although Hippocrates, shown here in this slide, who is often regarded as the father of Western medicine, uh, left us with a very rich array of observations. One of his books, called the Aphorisms, has pithy one liners which explain cause and consequence. And in another book of his, The Epidemics, he highlights various case studies of different patients. But the shift of medicine as art to medicine as science is not a recent phenomenon. 450 years after Hippocrates, this man Galen, whom you see in this slide as well, extended our understanding of medicine by observation by including experimentation. And if you read his work, you will be fascinated that a person who was born around 130 AD in what is now Turkey, but very close to the Aegean Sea, was able to develop experiments that attempted to go beyond structure to the function of the human body and of human nature. In fact, Galen had such a huge influence on medicine through his enormous set of writings that his writings were almost considered dogma for the next 1500 years in what we commonly refer to as the Dark Ages in Europe. And then Renaissance began, and the new spirit of inquiry came about, which led to the overturning of the dogmas of Galen. Vesalius was the first person who did human dissections openly and which were allowed by law. And in the process of doing human dissections, he overturned some of the understandings that Galen had, which through no fault of Galen, because Galen could not do human dissections. He was a physician to the gladiators. And so after the gladiators had fought their fights and came out with terrible wounds, he would look through the wound and observe what he could and then construct the rest of the anatomy through conjecture. Nevertheless, these changes came about. And in the 17th and 18th and 19th centuries, the French and German scientists had complete primacy in the area of experimentation, in part supplemented by by English scientists. It was the period when Jenner also described vaccination, and Louis Pasteur made his landmark studies, which introduced the idea of the germ theory, because prior to this, the understanding was that disease was due to the humors, imbalance of humors, and was largely carried by miasma or through the air, which is why centers of healing shut their windows. Patients were confined in very suffocating circumstances. And that's how we even get the name malaria, mal meaning bad, aria meaning air. And then after the germ theory was proposed by Louis Pasteur, his rival in science, Robert Koch, who was a German, went on to establish many germ disease relationships, starting with the discovery of Mycobacterium tuberculosis for tuberculosis. And then subsequently, there were many other advances, including the discovery of antibiotics. Now, through all this period when Europe advanced, America was a backwater of science. In fact, in medical science, conditions were so bad in America, there were large numbers of medical institutions, many of them not attached to hospitals. And so to this dismal condition comes Abraham Flexner, who publishes his report in 1910, where he advocates for a more scientific approach to medicine and the establishment of laboratories as part of not only medical education, but also as part of the investigation of patients. And the question is often asked, did the Flexner report, which was hugely influential, because from this time onwards, medicine strives to be a science. And it is at best an inexact science because of human variability. Doctors know this. Patients come with different presentations, but the same disease. They have different outcomes, although they come at the same stage of the disease. But the question is often asked is, did the Flexner report overlook the ethos of medicine in its blind passion for science? And the answer to that is, that was never Flexner's intent, because in a later article, he writes, I've spoken of experimental science, but what I say is true of music and art and every other expression of the untrammeled human spirit. The mere fact that they bring satisfaction to an individual soul bent upon its own purification and elevation is all the justification that they need. So he did not decry the humanities or the arts, but oblivious to his intent, medical education and medical practice progressed along the path of science, gradually moving away from the humanities and the ethos that it professed. And it took some landmark studies in the 60s and 70s, which forced the medical profession to evaluate itself. In this slide, you see a picture of Henry Beecher, who is noted for many things, but in this case, notably for his remarkable article in the New England Journal of Medicine in 1966, where, when science had been embraced by medical education, he discusses 22 papers in good journals from extremely prominent medical institutions, and he questions the ethicality of those papers. At about the same time that Henry Beecher publishes this paper, Papworth in the United Kingdom has written a whole book called Human Guinea Pigs, where he advocates for greater insight and oversight in scientific research related to medicine, again highlighting studies which he believes are ethically dubious. This was followed a few years later by a newspaper report published in the Washington Star in New York and the New York Times, journals today, publications today, which continue to receive the wrath of politicians. And in these newspapers highlighted a study called the Tuskegee study, which had been in existence for 40 years. In this study, Black Americans with syphilis were observed for their progress of their disease. Now, that in itself was fine, except that in the 1940s, penicillin became widely available, and these Black Americans were part of this study, which was supported by the US Public Health Service, so it was a government study, did not receive penicillin. They continued to have syphilis. They developed tertiary syphilis, which affects the brain, died, many of them died terrible deaths. But they continued to participate. They didn't even know they had syphilis. They had been told that they had bad blood. They continued to participate because the research nurse was a Black American herself. And so they had faith in her. They were given warm meals when they came to the clinic. They were given burial stipends, which meant that they could be buried without going into debt. All this was important, but what these events showed was the dichotomy between medicine as a science and medicine as an art. And so, with these studies that came about, many prominent doctors started asking the question, how can we bridge the divide between medicine as a science and the humanities? And this is ironical because scientia, which is the word from which science is derived, has got nothing to do with experimentation. It means knowledge. And so the humanities are as much a source of knowledge as experimental science is. But there were certain ways in which this could be bridged fairly easily. With these earlier anecdotes that I talked about of egregious errors in the conduct of studies and a breach of ethics, bioethics became one of the early bridges between medicine and the humanities. The history of medicine was another bridge because some very remarkable, prominent doctors who were not historians started writing extensively about the history of medicine in a narrative style that appealed to doctors. And finally, there was the advent of social medicine, which required doctors to look beyond their individual patients and look at societal needs or community needs. And yet, while attempting to bridge this gap, there was a huge divide between how medicine saw itself and how the humanities existed. The environment for medicine was largely biomedical, and the derivation of its knowledge was largely experimental, partly experiential. The approach was analytical, The reasoning for medicine was very linear, in other words, cause, effect, outcome. It strived to be objective so that it could stick to its evaluation as science, and it used largely deductive approaches, which is essentially hypothesis driven. And the major framework was that of falsifiability, which Karl Popper proposed. In other words, you could test a hypothesis and prove it to be false. The intent of medicine was to develop an evidence-based approach which could be applied uniformly to all patients. And the goal was to promote technical competence. Contrast this with the humanities, where the humanities approached health and medicine from a much wider prism, a biopsychosocial approach, a socio-ecological approach where environmental factors were important for disease and healing, and historical approaches as well, and some of these I'll come to a little later. They used analytical approaches which were quantitative, but also to a very large extent qualitative. As a result, reasoning was deductive. Their framework embraced the idea of plurality, of differing views, attitudes, and approaches. And the intent of humanities was a human-centered approach, which was individualized, where the individual was not lost on the altar of trying to promote uniformity. The goal was to promote emotional and interpersonal competence. And so in many ways, you see this Cartesian dualism where the body is celebrated by medicine and the mind, feelings, interpretation, and the tools to address them through communication, reflection, and empathy are celebrated in the humanities, while people who were attempting to bring this together could see the value of both for the patient, since it improved clinical outcomes, as well as the physician, because it improved resilience and self-care in the physician. And in the process, by bringing the humanities closer to medicine, there was a hope that certain skills would be developed in health practitioners, skills of wider observation, of critical reflection, of introspection, of flexibility in thinking, because medicine can be extremely rigid while it uses a linear approach, as well as a tolerance for uncertainty and ambiguity, which again is seen as a construct which opposes the practice of medicine, rather than which is something that should be embraced because it is a reality. So once humanities started coming into the medical curriculum, how was it seen within the medical curriculum? Well, we know that there are wide gaps between what the trends of medicine as they exist in India today and what the needs are. What we are creating are largely individuals with training, that is psychomotor skills, but not with education, either the cognitive or emotional quotient that should go with the practice of medicine. We have become increasingly commercialized. We have become increasingly technology-driven. We have been increasingly industry-driven in our approaches. And these are counter to what the needs of society actually are. And so when the humanities were brought into medicine, and I must say that these models are not for India, because in the whole of India, there are perhaps a handful of medical colleges which have embraced the humanities and health. These are data that have emerged from outside, because we are about 20 to 30 years behind the frameworks for humanities and health that have been in existence abroad. So one of the models for once humanities was brought into medical education, there was this model of acquiescence, where immediately there was an attempt to medicalize the humanities. And so you have the development of medical education, medical sociology, medical anthropology, everything medical. And in the process, the root values, the educational frameworks, and the pedagogy that is true for the primary disciplines gets lost. And so what humanities assumed in this model of acquiescence was largely an ornamental role. The humanities were nice for the subjects, you let them, for medical students, you let them put up plays, you let them write reflective narratives, but it's all on the side. It's all sort of things that they do when they have nothing better to do. And yet, there were some institutions where a model of resistance developed because the humanities became the focal points of an open space which questioned and critiqued medical education and medical practice as it existed. And there are some remarkable people who developed humanities and health in this model of resistance. So with that background of the humanities, which I wanted to talk about because there is often a very major misconception where the humanities and health and medical humanities are largely seen through the prism only of narrative medicine, I want to now move on to its application to lifestyle diseases, looking at a single model of a single situation of overweight and obesity. And what I will attempt to do is to try and bring some of the different types of inquiry which help us better understand the human condition, but using overweight and obesity as my handle. And the reason I do this is because there are associations of overweight and obesity which we would clearly see as lifestyle related. Cardiovascular disease, hypertension, diabetes, many other conditions. But even before we start looking at how the humanities can inform us about a lifestyle disorder, I think a fundamental question that I always ask my students in their very first lecture in physiology is, what is normal? Because medicine attempts to address the abnormal. And so how do we define the abnormal? I think it is easier to ask the question, how do we approach normal? And I say that in inverted quotations. So a health model would look at overweight and obesity with the basic premise of at which level of overweight and obesity would you be associated with the absence of disease. And over the course of a century of data, we have now large amounts of data across geographies, across ethnicities, which have demonstrated that there is a relationship between body mass index, which is an index of fatness, body fatness, and other parameters like the prevalence of disease, or in this slide, death. And if you look at this slide carefully, you will observe that the graph is J-shaped. You will observe that the lowest levels of this J, that is linked to the lowest levels of mortality, are around between a body mass index of 20 to 25. Below 20, so as people become more thin, their death rates begin to increase. As they become more than 25, their death rates increasing even more sharply as the body mass index increases. And this range is not uniform. In Indians, we use a cutoff of around 23 because we found that there is an increased risk of disease that occurs even at a lower body mass index. But this is one model, the health model, which looks at risk. But there are other models of body weight. For instance, a biological model might premise itself on optimal function. Optimal function. And in this slide, you see elite athletes. And when you just look at the slide, you can see that they have extremely different builds. In the center, you have an athlete who is a decathlete, who where you are required to sprint, to do throws, to do jumps, and you can see a larger individual, more muscular, as compared to these two individuals on either side who are much thinner. So body weight, according to this biological construct, actually looks at function. The question is, what function are you looking at? Yet another model is a socio-cultural model, where the basic premise is aspirational. Where would we like to be? And of course, where we would like to be is dependent on our social circumstances. In Polynesia, for instance, in the South Pacific Islands, being big was seen as as desirable, not because it showed that you were more wealthy, but because a larger size was an indicator of status within that community. Now, as a result of this, there are problems in this community. They have some of the highest rates of diabetes and other obesity related problems that exist. But this is nevertheless a social construct, and I'll come to this a little later. And then we have a model which is normative, where we attempt to describe what is normal on the basis of what our population currently is. But there is a problem to this normative model. In this graph, you will see that on the x-axis, we have age. On the y-axis, we have body mass index. And each of these lines represent a survey of people done at different time points. So the NHANES is a nutritional and health survey done in the United States. And you can see that this line reflects the survey in 1971-75. And then the lighter line, which I'm now tracing, reflects the survey in 88-94. And then the highest line reflects the survey still later in 99-2000. And what do these lines represent? They represent that at these different time points, across all ages, the average body mass index has risen. In other words, with time, our body mass index as a population is increasing. We are becoming more and more overweight, and that's a problem with using a normative approach, because it will keep changing. And this is true not only of the general population. Studies have shown that in Western armies, the average weight of a soldier has increased with the passage of time, partly because armies now are more technological, and also because the army personnel are drawn from the general population, where body mass indices are increasing. So that's about how we see overweight and obesity. That itself is a challenge. It is important for us to reflect on the language related to overweight and obesity. Language can be stigmatizing, but in this context of this talk, I want to talk about language as reflected by the stories of people who are overweight and obese, how they see themselves and how they see their condition. So I'm going to come up with certain quotes. Each of these quotes reflects a different person, and I'm going to read them because I think they are extremely powerful quotes. So you have one individual saying, when you are low, you just feel, oh no, everyone thinks I'm this great big blob, and it's horrible. It's hell and hard to get on with life, and you just feel big. It's so much hard work being this size. Another person says, it's not guilt. I'm too realistic to feel guilty. I don't think you should feel guilty about something you've chosen to do. It's more anger at myself. Anger. It's a sort of self hate. It's anger at my inability to stop eating. Yet another quote. I feel like I'm ugly. I'm a freak. When I take my clothes off, it's not nice. I won't let anyone see me like that. I do not like people seeing me and my boobs, my stomach. I've got fat on my back. Yet another. When I had my baby, they must have switched my body with somebody. I say it's not my body. There's a raunchy, skinny Cindy Crawford trying to get out. She's got to find the right orifice. I can't even lay flat on my bed. I have to have pillows under me because as soon as I lay down, because I am quite big chested, I feel like I'm suffocating. So I find it really difficult. So I sit up. I sit up almost straight. Freedom just to do things. Freedom to walk upstairs and back down again. Freedom to do my housework without puffing and panting. Just freedom to go shopping. I feel like I've had part of my life just taken away from me, robbed from me. All that I want, it's just really mobility. You see here in these quotations something that comes out from the patient that doesn't often get said at a clinic, because the biomedical model of health looks at overweight and obesity in terms of its immediate cause, which in its simplest form is an imbalance between energy in and energy out. The food that you eat, the energy that you consume, and the energy that you expend through all the activities in the day. And so when you have such a simple model, you're really not concerned about all these other issues. The biomedical model seeks to find a solution. And the solution is not necessarily for the problems that the patient faces, but to address the parameter of concern. And the parameter of concern is perhaps BMI. So when we neglect the stories of patients, it matters. Because what we do when we ignore the stories is we over-medicalize the patient's condition. And we ignore the patient as a knower. This is important because the person who can best understand their own condition is the patient themselves. There is no doctor who knows what the patient is going through. There is no doctor who understands on a day-to-day basis how the patient views their own illness. And this is a form of what we call epistemic injustice, where we dissociate the patient from their own condition and treat them as ignorant, as a case, as a test, as something that has to be addressed, rather than as what their lives are. And this form of epistemic injustice is both testimonial, where we do not listen to we tend to minimize or trivialize the history of the patient. So we are constantly looking at the history as filling in our dots, joining our dots, which we have already preconceived. And it is also hermeneutic, where we are constantly interpreting the patient's history and trying to assign a meaning to it which we are comfortable with, rather than what the patient is actually trying to convey, or the person is trying to convey. Language is reflected in literature, and this is a poem by a Canadian poet called Missing Link in the Food Chain. And in this poem, it's a short poem, he says, all around us is an epidemic, man-induced plague. It's a conspiracy to hook people to non-food foods, eats that should be technically inedible. Anything to grease the wheel of factories and consumerism, nothing grown naturally, nothing from a farm, heavens no. And in this very brief poem, what we can see is a lot of elements of truth. So poetry can reflect accurately sometimes what the world is going through. And in many ways, it is popular literature which actually reflects the human condition in illness and disease far better than any of the medical writings that exist in journals. This is true for any number of conditions. There are amazing stories written on cancer. There are amazing stories written on a lot of other conditions. And these stories tend to be sanitized in medical literature. And yet, we need to be a little careful when we read popular literature. Here's another poem called Rampant Obesity. And it starts off, pot belly was the pride of the wealthy. The fatter they looked, the richer they were presumed. Nowadays, the rich have found the source of energy by staying in shape and looking haggard. Rampant obesity is a real problem for the common people. And when it comes to eating habits, they are pound foolish, obsessed with a fat cuisine, tasty, elaborate, and incorrigible. And without the aesthetic concern, they try every alluring dish. Well, there is truth in this statement, in that what was formerly considered a condition of prosperity is now a condition that affects the poor as well. In India, overweight and obesity is very high in urban slums, and increases about 3 to 4 to sometimes 5-fold from siblings who remain in rural areas. But there is a problem in this poem, because having shown this dichotomy between the rich and the poor and the change that has occurred with time, the poet then goes on to assign and to judge the people who have now become overweight and obese, and in a sense holds the individual responsible for their own, for what they're going through. And this denies the social and even the commercial determinants of health, which I will talk about. Art is also a great depiction of the human condition, and in very old sculptures of fertility, you can see here that fertility goddesses were always depicted as voluptuous, as overweight. And that is because people recognize that for successful reproduction, the breasts and the pelvic girdle were important. And so for the fertility goddesses, they amplified those parts. But the body has also been displayed through the ages. Rubens and Renoir, depicted here on the two paintings on the left, typically showed the women as being voluptuous. But even through this period, other artists who were trying to depict reality as they saw it, and this is shown in the painting of Frans Hals of Dutch officers. You can look at those pictures of the Dutch officers and you see people who are clearly what we would say overweight. He even goes on to repaint them 20 years ago and shows the progression of that person. And there is a social construct for that Dutch image because it depicts a time when the Dutch were wealthy. You see a table that is filled with food. And is this the aspirational image of what we should construe as normal at that time? And yet we need to look at art more deeply because here you have on the left-hand side two paintings of Picasso at a time when he was not doing well in his early stages of his career. And you can see that he himself impoverished, depicts impoverishment in these two pictures of a woman ironing and what he calls a frugal meal. And by the side of that, you have this very famous painting of Van Gogh, The Potato Eaters, less of his impressionistic style, but really depicting the very dismal conditions of people at that time. And so why it is important when we view art that we view art in the context of its history, of its social situation at the time, but also in terms of the artist, because time is short and I can't go into this, but a lot of medical paintings are celebratory. And in trying to celebrate either individuals or events, they veer dramatically away from the truth. And so have to be viewed with caution. But art is again another way in which we can understand the human condition. And then we move on to social constructs, and these are too many to go through. So I will focus on just a single issue of body image, because it clearly is an issue which is of concern. It can be stigmatizing. It can be related to body shaming. Even today, this is a picture from the BBC in February of 2025, where it says body positivity takes a backseat as fashion houses pick skinnier models. And this is important because people start looking at these aspirationally. Body image is not something which only occurs in adults. It is seen in children as well. In this study, for instance, we showed that underweight children were 10 times more likely to overestimate their current weight, while overweight children were 4 times more likely to underestimate it. And this is also reflected in their parental perception of what their children are. And these are also important because the body image is reflected differently across socioeconomic statuses. Why is body perception important? Because it often drives behavior. In this study, we demonstrated that if we looked at weight loss behaviors, we found that individuals who were normal weight, but who perceived themselves as overweight, were 3 times more likely to start interventions at reducing their body weight. And for people who were overweight and saw themselves as being overweight, they were 16 times more likely to use body weight reduction interventions. And there was a very steep curve along this whole grouping of people as they were and as they perceived themselves, which tells us that perception of body weight and body image is a huge factor which we need to take into account. Another social construct of of body weight involves the issue of migration. uh, India is increasingly becoming urbanized. We are still some ways off from many other countries, but it is happening. And what we observe is that individuals who move from rural to urban areas, regardless of their socioeconomic status, but often most vividly seen with people of low socioeconomic status, increase their body weights, and women are disproportionately affected because there is not only a loss of kinship, a loss of social circles, but they move into an environment which is less open, where their work tends to be as domestic help in more confined spaces compared to agricultural work, which would have required them to do very different type of work for prolonged periods of time. And this is very striking. The social construct of migration is associated with other things. There is a change in eating behavior. Street food in India is energy dense, high fat, relatively cheap. And we observe that among migrants to urban areas and in people in urban slums who've been there for some time, there is a considerable amount of eating of street food, which is unhealthy. Another thing that we need to take into account when we develop social constructs, and there are any number, I'm just picking a few out of a hat, literally, is the issue of tracking. We are what we are today because of what happened when we were younger as well, and some of our behaviors track into adulthood. So, as a population, and I have to emphasize this, not as individuals, because we can always change our behaviors, but as a population, physically inactive children tend to be physically inactive adults. Children who have high blood pressure tend to have high blood pressure in adults, as a population, not as individuals. And this whole idea of tracking from schools right up to adulthood is something that begs us to intervene at a very early stage. First, to understand what it's all about, and then to be able to intervene. I told you that ethics was one of the bridges between the humanities and health. And so I want to talk about some ethical issues in combating overweight and obesity. One of the ways of doing it is what we call hard paternalism. We can enforce laws, we can enforce rules. And in this graph, this map, which was generated by Barry Popkin, who has studied the nutrition transition perhaps more than most people in the world, he shows the countries in pink which have sugary drink taxes around the world. You can see that some countries have them, but the vast majority of them don't. There is a reason for that. The sugar lobby is extremely powerful. Nutritionists have often had a conflict of interest because they are on committees which decide nutrient requirements, but they also have a conflict of interest because they work for industry or they have other ties to industry. Another example of hard paternalism, where the state acts like a benevolent father, is, for instance, in the introduction of compulsory nutrient labels on packaged foods. And industry has embraced this. They have said this is a wonderful thing. And many years ago, I attended a lecture by a very well-known person called Judith McKay, who was at the forefront of trying to reduce smoking and tobacco consumption. And I can never forget what she said. She said that when industry supports your initiatives and when they even give money to promote it, rest assured that they have done their homework, they've done their market surveys, and they know it isn't going to work. But the moment they start complaining and they say, for instance, this is going to affect livelihoods, you know you've hit on what is likely to be effective. And taxation works. Another thing, construct because people react to paternalism, because when the state tells me what to do and everything that I have to do, particularly in the West, there is this sense of a breach of autonomy, my own choice. And this is why during the COVID pandemic, people often, you had these anti-maskers, people who said, I will not wear a mask. It is my choice, it is my life. There is a wider issue of solidarity, which has, and the common good, which has to be embraced. But this is nevertheless a very powerful thought in the Western world, not so much in India or indeed in Asia. And to counter this, one of the things that came about was this idea of nudge, or what is often called soft or libertarian paternalism. Taylor and Sunstein wrote this wonderful book, very readable. And in the early part of their book, they had this example which they showed the cleaners in Schiphol, Amsterdam airport, were complaining that in the men's urinals, there was a lot of urine spillage on the floor, and they had to constantly be cleaning it. And what they did was they used nudge theory and painted a fly on the urinal, and the spillage reduced 80%. Now, why am I telling you this? Because the same idea of nudge has been applied to overweight and obesity. So here you have it being applied to increasing physical activity. You have a staircase with a musical steps so that people make sounds. So children keep running up and down. People who play the piano well enough might even be able to play a tune. And then you have these other things where you allow your calories are counted as you walk up the stairs, or when you go to the elevator, it tells you the elevator is very slow, the stairs are faster. And even this very catchy poster which says, it is not enough to stare up the steps, we must step up the stairs. So there is an attempt to nudge people, to push people towards a certain direction. And studies have shown that nudge theory can also be applied to the way we eat. For instance, if supermarkets start placing fresh foods closer to where the checkout counter is, then you find people buying more of this. In actual practice, it's usually placed deep into the supermarket, and at the checkout counter you have chocolates and everything else which people start picking out just when they're about to pay. And this applies to cafeterias as well. So what you present to people as a first choice and how you present it and how you make it as inviting as possible affects behavior. So people argue that nudge was ethical because while it altered people's behavior in a predictable way, it still did not limit their options. You could choose to just ignore the nudge and do whatever you wanted. On the other hand, people started saying that nudge was nothing but paternalism in disguise. It was an abuse of power. It impaired autonomy. And so, like most things ethical, this requires a considerable amount of deliberation. But you can see that understanding ethics, and ethics is a part of humanities, enriches our understanding of how we approach overweight. So does history. We've often looked at history as something that's just something in the past, and what has it got to do with body weight? And when I was a young postgraduate student in physiology, I was fascinated by these Native Americans in North America, the Pima Indians, because there were huge numbers of papers which were coming out at that time, which were explaining to us how Pima Indians had very high rates of overweight, high rates of diabetes. There were a lot of experiments conducted on them. And I never gave it a thought. I was so taken up by the science. And later on, I started thinking about it. And of course, the Pima Indians have become steadily fatter, not because they were always that way. They were, in fact, very lean when they were hunters and gatherers, and when they moved across the last swaths of land that they owned. But when the white settlers took over their land and then confined them to very small areas, and then flooded the stores where they were with very subsidized, high energy dense processed foods, that's when the problems started occurring. And in the process of confining them, bonds of kinship were destroyed, their social structures were destroyed, and they developed a lot of problems, lifestyle problems. This is mirrored in a lot of areas where acculturation has occurred to native peoples in Canada, in Australia. And so it is important for us to recognize that historical construct, in part to understand and to acknowledge that the problems that they face are actually problems that have been inflicted on them, but also to engage with them so that they can develop the interventions that allow them to successfully reverse these conditions. Another example of how a history can help us understand overweight and obesity is Barker's Fetal Origins of Adult Disease. In the left side, you see a picture of a mother who is very thin. This is actually refers to the Dutch famine late in the Second World War. While Hitler was losing the war, he basically stopped food supplies to the Dutch people. Many Dutch women who were pregnant at that time, therefore, did not have sufficient food to engage for their pregnancies. And the children were born very low birth weight. But although they were born low birth weight, the children later on went in adulthood to develop obesity, diabetes, hyperlipidemia, and heart disease. And Barker created this construct of the fetal origins of adult disease. And you see a picture by the side which gives you the physiological basis. It constantly gets updated because a lot of work is being done. But this is again historical, and we need to recognize, otherwise we start seeing conditions of lifestyle as of the here and now, while a lot of it has got to do with the past. Economics is also important. There are commercial determinants of health and disease, and also obviously of body weight. This might seem strange for us at this time. These are old advertisements which promoted lard or animal fat as a cooking medium. And you look at the captions, they're happy because they eat lard. They're young, they're in love, they eat lard. Today, this is almost inconceivable that this could even have happened. And yet, lard was a cooking medium. And before the fall of communism in Europe, the Iron Curtain separated Eastern Europe from the West. Eastern Europe largely used lard in their cooking. And when the Iron Curtain fell and vegetable oils were brought in at low cost for people, and people shifted, cardiovascular disease and mortality reduced substantially. We need to recognize that food today is the function of large monopolies. And these large monopolies control not just our processed foods, but because they are so large, larger than the gross domestic product of most countries, they also control the supply chains. They control what farmers grow. They control what farmers produce and when they produce it. And this reduces the diversity of foods. In fact, it has reached a stage where to have a diverse diet is something that only the rich can afford in countries like ours. But commercial determinants of body weight go beyond just companies. As the wheels of progress, commercial progress, turn, we find that our living spaces change. Pavements become narrower as roads have become wider to take the thing. Commerce is not just about big companies. Commerce is about people who are trying to make their livelihoods, but who take over the footpaths. And of course, we have these bike riders who I have no sympathy for, who come onto the pavements. And where in all this will we ask people to walk? So we get a person who is overweight, who wants to walk, and we say, yes, walk 30 minutes briskly every day. and when that happens, and then they ask the question, where? So these are part of the commercial. So what of the future? I think that in the future, I look to a future where the humanities in health and the medical fraternity are see the synergy of what each area brings to the health of the patient, to the health of society, and to the health of the health practitioner as well. Because the humanities in medicine have clear value. Edmund Pellegrino was a physician and an ethicist who is in many ways the father of what was formerly called medical humanities. And he promoted it because he said the humanities are essential to ethical and value issues. They're also indispensable to critical self examination, and they confer those attitudes of mind which distinguish the educated from the merely trained. That's an extremely powerful statement. It begs us to introspect. William Osler was often considered the father of modern medicine, said it is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. He promoted the humanities in health in a major way, and his writings are wonderful writings. They're good for anyone to read. He said that it is important for reflective practice, it's important to understand plurality in medicine, it's important to understand empathy. We live in a world which has depersonalized and dehumanized people. We have conflicts raging where so called collateral damage affects so many thousands of people, which could only occur because we have depersonalized and dehumanized them. They have no longer become human, they have merely become a statistic. Empathy is something that's extremely powerful, but there is a problem. Can health practitioners, whatever they are, always empathize? And I would like you all to consider that empathy could be of two kinds. It could be emotional empathy, where we feel with the patient, and that might not be the best thing when you're making decisions for patients and you have to, in some way, keep a distance so that you have clarity of vision. But there is also cognitive empathy, where you can at least understand what the patient is going through. So, what are medical humanities or health humanities good for? It definitely reduces the gap between biomedicine and the human sciences. It facilitates interdisciplinary teaching and research, and we need that to understand the human condition. All that I've told you about overweight and obesity, if nothing else, should allow us to understand that we cannot understand the human condition without being interdisciplinary. It promotes a patient centered approach to medical care, it counteracts professional burnout, it reduces medical hubris because we are so carried away by what we do and how wonderful we are, and it equips doctors to meet moral challenges. I'll end with a quote by Mae Jemison, who was the first colored astronaut to go into space. She was a physician and an engineer. And she said this remarkable thing. She said, sciences provide an understanding of a universal experience. Arts are a universal understanding of a personal experience. They are both a part of us and a manifestation of the same thing. I think there is no doubt in my mind that medicine is an art and a science, and that it cannot exist separated from the humanities. Thank you.
Thank you, Dr. Mario, for your enlightening talk. We will now open the floor for questions. If anyone has a question, please feel free to unmute yourself or type it in the chat box. Anyway, is appreciated, and we will address them one by one. We look forward to an engaging discussion, so please don't hesitate to share your thoughts or queries. Just one thing before we move on, please note that the feedback form for this particular session will be shared via email, so please have an eye out for that and fill it whenever you get the link. Yes, the floor is open now for questions.
Um, Hi, Dr. Mario. First of all, I think it was a really insightful conversation. I just wanted to understand a little bit about what your perspectives are on Ozempic and the weight loss drugs that are coming. And almost every endocrinologist I follow talk about curing obesity, but at the same time, I see so much shame about from mostly fitness influencers, fitness coaches about how Ozempic is the shortcut for obesity and how discipline and motivation is the way to go. So I just want to understand your perspective on how do you see this dichotomy, and what are your thoughts on it?
So I think as a general thought, I think medicine has always looked to medications uh, as as a solution to what problems are. And in that respect, overweight is not unique. If you look at cardiovascular disease, for instance, the poly pill is promoted. So you have a single pill with multiple components which control your blood pressure, your cholesterol levels, and things like that. Now, do they have a place? Yes, they do have a place. But I think what we need to recognize and is to understand that we really have to understand where the individual is coming from. And that's why I talked about the patient's stories and epistemic justice, because if we approach the problem biomedically, then the first response that we have is to just provide the pill and just go ahead and say, well, that's your solution, and it's the fastest. And I have had many people talk to me and tell me, why do you look at these other issues? Because they are unsustainable. Behavioral change takes time. Behavioral change doesn't always work. And that is because the individual faces barriers and facilitators of their own. It's not uniform for everyone. And sadly, we have a lot to do in India to understand these other components. Most of the literature that you have is from abroad. Medical sciences is traditionally very, they view qualitative research as being sort of secondary research. And although that is changing, and it's changing not because the medical fraternity feel that it's a good thing, it's changing because research funders are demanding that you have mixed methods when you approach things. So it's not like they're really driven because they feel that it's a wonderful thing. So the bottom line, what I'm trying to say is that we cannot use an approach which is an industrial approach where you're mass producing results by having a one size fits all. And to be fair to the medical fraternity, there are problems that they face. I mean, a major problem that the medical fraternity faces is that just look at the numbers who come into a hospital. So whenever I talk to my classmates who are abroad, they say, I cannot understand why patients get, we see 15 patients and that's what we see. But in India, we can't control people entering, and they have every right to enter. So before you know, you've got 300 people there, and they all have to be seen because they all have lives and they go. So there are real challenges. But the bottom line is, I think we need to, I personally feel we need to bring in a lot of non-medical health professionals into healthcare, into health education. It works very well for certain disciplines, okay, but in certain other disciplines, uh, yeah, those people are not necessarily seen as being central to what the patient needs. So we have a long way to go.
Thank you. Um, I just want to say that the session was really helpful. It was very resourceful, and I also come with a doubt. So, in my perspective, it seems like wellness industry is something and illness industry is something, and hospitals seems to be catering more to the illness side of it, especially with the medications and the narrative about health. And given India's like cultural context, it's very difficult to navigate this and help people identify the right health resources because they also go into like superstitious practices or their belief systems or shamans and things like that. And so when there's so much diversity and there's a huge population looking for the right resources, how can we actually navigate it, like especially being a health professional and coming into this field?
Yeah, I don't have an answer to that actually, because I think you highlighted a problem that clearly exists. All right, I think I think we have to also accept the fact that the health, wellness, healthcare space is hugely commercialized. So when we say that people have a difficulty in navigating that, the difficulty in navigation for me is at both extremes of the socioeconomic spectrum, because you have people who do not lack the monetary resources and who will keep going from one place to another and have the ability to do that. All right. And then there are those who at the other spectrum also are extremely confused because they uh, they are brought up to believe that there are certain systems which are less um beneficial than others. Private is always better than public. It's not true. Okay, I think that, but that's how they view it, and so I have no solution to that. I think that there's an attempt to regulate some of these. So, for instance, the National Accreditation Board for Hospitals was an attempt to regulate the healthcare space. But it has become a space where people now use the parameters that they know are going to be assessed to basically achieve that accreditation. So there is the attempt at accreditation was to improve quality, but what you see is people view it as compliance and a certificate which they can show that they have achieved. So it's not an easy solution, and it's not an easy solution anywhere in the world. The places which have successfully sort of addressed this are those where the social welfare systems are so strong and where they have committed themselves to spending a significant portion of their GDP on healthcare, but as social welfare models, because the United States spends a huge amount of money on its health and it achieves very little for it because the system is tiered and it's privatized. And it's largely owned by industry and insurance. But if you look at models or in the Scandinavian countries, for instance, that is something. Now, I wouldn't be too dismal about it, because I think for me, what is really exciting is the way public healthcare systems have improved over the years in India. And a very striking example is Tamil Nadu, where the public healthcare systems work. A large enough percentage of people access the public healthcare systems. There is, of course, the private healthcare system, which will always exist because there is a niche, the area that they provide in terms of their services and in terms of the patients who see them. But I think there is room for optimism, and the fact that there are the public health insurance schemes that exist allow people to access a lot of healthcare which they couldn't in the past, is really wonderful. The health and wellness part, I think, is a bigger problem, because that is, as far as I know, unregulated. And I think this gives rise to such a profusion of people. The only way people can navigate it is really to do their homework as well as they can, but with the realization that it may not always work. And you may end up. And that is why in healthcare, second opinions are most commonly sought. I mean, and we encourage people to get a second opinion, because I think it is important for people to be reassured that they are making decisions which they are in their best interests.
Right. Yeah. I understand the perspective that you're putting here, and I think it's really helpful to see how regulation and how, again, social welfare models can be really helpful. It's something that we as students can be curious about and look into. So thank you, sir.
Yeah.
Sir, I have a question. In one of the last slides, you mentioned that medical humanities can be used to counteract professional burnout. Could you shed more light on that particular point?
Yeah. So there are obviously areas there are obviously areas in medicine where burnout is more common than in other areas. So, for instance, emergency medicine departments, intensive care units, people working with children. These are areas where professionals can get burnout because they are because of the emotional investment that is required in these. However professional you are, because you are taking decisions very rapidly, you have to not only deal with what the patient is going through, but what you can provide in those circumstances. For instance, during the COVID pandemic, moral distress among doctors was extremely high in those hospitals where patients were constantly being referred. I know St. John's had 700 beds which were kept for COVID, and they had huge numbers of beds which were high dependency unit beds, which meant that they were providing non-invasive or invasive ventilation. And so patients were being sent there. Now, very often, the doctor had to make the decision about how they allocate patients to certain types of beds, and the beds may or may not have been available. When it first started, uh, particularly junior doctors were going through a large amount of distress. And we had to develop a system which would take that doctor away from the decision making, so that they could use some sort of an algorithmic and staged decision making, so that they didn't have to live with that moral distress, constant thinking, did I make the right decision? could this patient have been saved or could not? So the humanities is used also as a tool to promote, for instance, journaling, reflective writing, um, uh, and for those who see art as an outlet, all sorts of things to actually come to grips with your emotion. Because, psychologists are often taught about transference, and you'll learn how to deal with it and all that. Medical doctors never are. You go through it, and you sort of end up having to learn on your own. And some people do, and some people find it very difficult to do. So that's where the humanities can actually come about. And a lot of the things that you all go through should be what medical students should also learn.
Thank you so much for answering that, sir. Do we have yes, yes, please.
Can I ask?
Yes, please go
Yeah,
ahead.
please go ahead.
So good evening. My name is Soumya. I'm a lecturer from St. Joseph's Pre-University College.
Yeah.
So you were mentioning about encouraging people to go for a second opinion.
Yes.
With due respects, however, sometimes when we go for a second opinion, we are asked to redo all the tests from the beginning. Now, for a person who's coming from a difficult background, sometimes not apart from suffering from a particular disease, financially also that puts a lot of burden. Probably sometimes it's necessary, but otherwise, is it because of some of these corporate hospitals having, pressurizing doctors to, have targets to meet and things like that?
Yeah. So I think that when I talked about second opinions, I'm really talking about situations where uh, there is a, a life-changing event, right? So where there is an illness has been diagnosed, and the course of treatment that is may need to be done is either very intensive or very prolonged or very expensive or things like that. So that is where I think a second opinion really matters. Uh, the problem that you have alluded to is a problem of the commercialization of the healthcare space. Unfortunately, we when we talk about private or commercialized healthcare, remember that we are talking about a range of hospitals which exist. So there are not for profits, there are for profits, there are small nursing homes, and there are uh, people asking for repetition of investigations could be due to two reasons immediately, which comes to my mind. The first is that because it's commercialized and because investigations are a major source of income, the person is asked to do it, and there is a huge expense for the person. But it could also be sometimes that tests are asked to be redone because the first set of tests that are done may not be done in an accredited laboratory, and the tests are in doubt. So, in that situation, when the doctor feels that the tests, they may not have confidence in the test results, then they may ask for it. But the issue that you raise is part of a wider issue of commercialization of health space. Remember that it is not unique only for health. Education itself is commercialized. You're a part of a university. Is it not commercialized? It is commercialized. And that is where we have to, I don't know, we have to be able to help patients better navigate the healthcare system. It's not going to be easy when you have a multitude of healthcare providers. But I think that as people become more aware of what is available to them, and in many ways less mistrusting of the public healthcare system merely because it is public. We will see some of these issues being resolved. And I know that for certain illnesses, there people do try and raise money so that people who are poor can be treated. But the bottom line is that healthcare is actually a responsibility of the state. The healthcare providers who come in because there is a gap, and if that gap is filled, they have no reason to exist, or they have a smaller reason to exist. So it is part of a much larger malaise which needs to be addressed.
True. Thank you, sir. Thank you.
Yes, with that, we have come towards the end of the session. I would like to take this moment to thank Dr. Mario for delivering such an insightful and thought-provoking lecture. Sir, your valuable perspective on medical humanities, what it is, why it is important, and the way forward will definitely help a lot of us. And especially when you said something along the lines of we should see what kind of person has a problem and not what kind of problem a person has, that will stay with me for a bit. Thank you for that. I would also like to take this opportunity to thank Dr. Surekha Chukalli, Dean of the School of Psychological Sciences, for her constant encouragement and guidance. I extend my appreciation and gratitude to Dr. Sudesh NT, Head of the School of Psychological Sciences, for his support and leadership. Heartfelt thank you as well to Dr. Manjusha Warrior and Dr. Patrick Jude, our session coordinators, for their dedicated efforts in making this event possible. My sincere gratitude to the organizing team, all the faculty members, students and practitioners who joined us today and contributed to making this session a success. Thank you so much for your participation and support. And we really are grateful to all those who have been with us throughout this lecture series. So thank you everyone, and have a wonderful evening ahead. Thank you.
Thank you very much. Thank you.
Thank you, sir.